with the academic quality role. Also making sure that there is supervision and guidance, again trying to offer that excellent leadership role there. The former dean noted that there is need to guide, promote, and support the contribution to new knowledge, and that is the research leadership role. Next. Examples of the administrative roles, of course, the dean has to give the school a strategic leadership direction, has to instill that vision and give the future direction, has to help the faculty development, and also to make sure that the graduates of the program are of good quality. These are really professional and administrative leadership roles that we've seen. Then we went on to look at the key competencies and analyze the data for that. Next, please. And we came up with 3 key categories of leadership competencies that the dean should demonstrate, or that we should look for. After looking at the codes and the themes and the codes that arose from that, these were the categories that we came up with. First of all, there is a personality that the dean should demonstrate. And we are going to look more at this later. But most importantly, they should also have the readiness to learn. Sometimes as deans, we get elected and think we are the alpha and the omega of all about medical education. But we should be really open to learning. Of course, in the category of education, a dean should be a medical expert in their field, and preferably a practitioner. They should have undergone some training in medical education, or at least health professional education, so that they have an informed view of what they are advising the faculty to do, and their bosses above and other stakeholders. Of course, they must be able to lead research, so they must have the competency of research. They must lead in research. A dean who doesn't research cannot tell the others to research. And we normally look at that category number 2 as the theme for us. We forget the personality and we forget the organizational skills. We just say, oh, that is he an excellent surgeon? He's been in the field for 20 years. MoH KENYA-AFYA. He has 100 publications. This is our thing. That is not all, ladies and gentlemen. There must be personality. But more so, there must be organizational skills to lead the faculty forward. Must know how to handle people. The people management skills are actually very important in team building. The work ethics must be a person of integrity, a person that follows policy and process, must be able to manage the finances, but also to draw those finances to the school as a financial mobilizer, resource mobilizer. Should be able to communicate and harness collaborations, both within the university and with other stakeholders. Most importantly, the dean should be a change manager. We are now addressing change. And if we don't manage change and know how to manage it, it will manage us. And there are skills for change management that the dean should be able to demonstrate. Next, please. So those are some of the exemplars that came through. Should be a medical educator, should be a person that demonstrates honesty, and should be a
qualities that have been described by Patrick, Professor Patrick. And what I wanted to ask Professor Patrick, and probably Kariuki as well, who is best placed to determine this leadership and competencies in academia? Because we have universities where the dean is appointed by the management, and we have universities where the dean is elected as a peer leader of his colleagues. And I believe, in my own perspective, is that the colleagues are very well capable of identifying all these qualities that you have expounded. But still we have, for example, University of Nairobi recently, in reforms, retracted and went back to the deans that are appointed by the management. What should be the clear position of academia with regard to this kind of leadership? Thank you.
Okay, or can I convert that question into, can you make a policy recommendation? Can I just have one more? Maybe the lady over there, I think she had her hand up. So with that, we'll, please excuse me, we'll close it with that so that we don't get too far behind in terms of time.
Thank you, Chair. My name is Dr. Julia Songok. I'm a pediatrician. I work for MoH University in the Department of Child Health and Pediatrics, and I'm currently the Associate Dean, School of Medicine, MoH University. Chair, I have a question on transition between a former dean and a current dean, the way you presented. And my concern, and this applies to most offices, is the transition usually is so sudden. It's actually between a Friday and a Monday. And if you don't have the goodwill of the former dean being open to being reached out, you really waste so much time trying to reinvent the wheel. And you know very well that the exiting dean knows a lot, not just from the work that they did, but even just the experience and the connections and networks that they have formed. So I've seen in the first world where you have a transition period that both deans are still taken care of very well by management to make sure there's a 3 months, 6 months between a former dean and an incoming dean. More so for very young deans like us who have to keep calling our teachers. 60% of my staff are my teachers, so it becomes very difficult. Thank you so much.
Okay, thank you. Could you please bear with me? I know there might be more questions. Can you please put them in the Secretariat email, and then we'll follow up the answers with the speakers, because those questions are relevant to us even when we write the final report. So please, if you have questions, just send it to the Secretariat. So I open the floor.
Thank you very much, Chair and members, for the very insightful questions. My apologies for going more medical. This is the study that was done, but like I said in the beginning, these are most probably transferable to other health professions. So where the colleges are all united, probably that should be applied. Who determines peer versus appointment? I think we do have a Universities Act in this country, like we do back home, which largely governs public universities. What informs that act are usually people that are not in medical education or even in university management sometimes. As academicians, we tend to shy away from political landscape, and we think it is for those that did the arts. This now means we've got to get to that table as well and be able to influence our future. So that said, I think there is a weakness in either of the two. Voting could be that the entire faculty wants to vote a dean who will not stop them from going to moonlight, for example, in Nairobi Hospital or whatever. Election might also mean that there is a leader who wants to pursue a given project, and therefore they will elect the dean that will help them sail that project through. That's why we need now to look at the competences so that there is an objective approach. Looking at the transitional period, I think that's important. And that's where in the recommendations, unfortunately, we couldn't get to the slide,
I was looking at training of incoming deans, and that training involves that transition period. Thank you very much. Okay, thank you very much. I think that brings us to the end of this session. My colleague here has told me that all these questions have been answered. So I'd like to thank the presenters. I would like to thank you as participants. I would now like to hand over to the next presenter. The young lady wants to tell me something. Can you allow me to hear?
Thank you very much, Professor Patrick and Dr. John Kariuki. Our chair, Dr. Ogendo, thank you very much. We're going to be moving to the next session. And before we move to the next session, I'd like to remind you, the sessions are only 20 minutes, so please let's keep time. The first 15 minutes are for discussions, and the last 5 minutes are for question and answer. So the next speaker in session 9 will be Dr. Mary Wambaria, and the session is going to be chaired by Dr. Gathara.
Thank you, everybody. I'm Dr. Gathara. I'll take you through the next 3 sessions. I'm requesting all 3 presenters to please come up onto the dais. Our first presenter will be Dr. Mary Wambaria. She'll be presenting on aligning health professions training with competency-based curriculum reforms in Kenya. Welcome, Dr.
Thank you, Dr. Gathara. Excuse me.
Team, we're requesting for the updated presentation with the logo. 1 minute. Dr. Theory, please come join up there. And Professor Mumbo, if you're in, we're welcoming you to the dais. So as they're sorting out the PowerPoint, I'm requesting the 3 presenters present. You kindly note your questions, and then we'll address them together. Or maybe, Dr. Wambaria, you could be telling us a little bit about yourself as we wait for the PowerPoints.
Thank you. I think I can start. Good afternoon. So, thank you. I am Dr. Mary Wambaria, working at the Kenya Institute of Curriculum Development. And this afternoon, I want to acknowledge my CEO. I don't know whether he's still there, Professor Charles Ogondo. I think he has walked out. And I'm presenting this on behalf of Kenya Institute of Curriculum Development. And my topic for this afternoon is aligning health professional training and curriculum in Kenya with the curriculum reforms that we have in Kenya. And I'm going to cover 3 areas. I'm going to look at the rationale of curriculum reforms in Kenya. And when I talk about the curriculum reforms in Kenya here, I am focusing on the basic education curriculum. Then I'm going to look at what are the components of this competency-based curriculum in Kenya for both basic and also the teacher education. We have 2 frameworks currently. And then I'm going to ask the question, what are the implications of these curriculum reforms to the health profession curriculum and training in Kenya? Next slide, please. So I want to introduce the Kenya Institute of Curriculum Development because that is very important, that we are the institute that is mandated to develop curriculum and curriculum support materials for all levels of education in this country apart from the university. So in all levels of education, we are mandated to develop the curriculum. And our curriculum is research-based, is evidence-based, and all these have to respond to the needs of the society. Next slide. And the competency-based curriculum that is in the Kenyan context has been introduced in Kenya. It started in 2017. Currently, we are in grade 5 as far as the system is concerned. And this is replacing what we are calling the knowledge-based curriculum, and which was started like 32 years ago. And the 844, of course, we all know that was established in 1985. That's when we got the 844. And this is the one that we are phasing out. So it is a phase-out kind of system, whereby we still have the competency-based, still learning the other knowledge-based curriculum. Next slide. And we are basing the reforms in our basic education and also in teacher education on various documents that we have. And that's why I say that it is evidence-based. We have the task force of 2012, and the task force of 2012 recommended that we should have a competency-based curriculum. And there were other recommendations. For example, we needed also to integrate values in our system. We needed national cohesion, and also it also advised on what kind of curriculum, competency-based curriculum we should have. And it also recommended that we should have flexible pathways. There is a slide on that will have flexible pathways. That is at the senior school. And that is the Odhiambo report, Professor Odhiambo's report of 2012. Then we have also the Constitution of Kenya. We have the Constitution of Kenya 2010, and the Constitution of Kenya 2010 is very, very clear that it is the right of every child to be provided with education. Not only every child, but also the children who have special needs. So it takes care of that. And also we have the Kenya Vision 2030. It was very, very clear about reforming curriculum, and curriculum is one of the aspects in the social pillar of our Vision 2030. Then we have the summative evaluation. This is the evaluation that is done at the end of the cycle of a system. So in 2009, KICD did an evaluation, and the evaluation so that still the curriculum needed to be reformed, and because there were a lot of overload in some subjects, there were overlaps. That is, you find that similar subjects were offering the same content, and it recommended that it should be revised. Again, also, it was more of exam-based, too much of examination. And also we have the East African framework, which also recommended that we should have a system that can cut across all the East African countries so that our children can be able to learn from any of the countries. So also that one also based the rationale why we reformed our curriculum. Again, we have number 6, what I wrote, global standards. And global standards recommend, that is the UNESCO IBA, International Bureau of Education, recommends that curriculum should be reviewed after every 5 years. Then we have the SDG. All of us know about the SDG. And I know in health you have your SDG, but in education we have the SDG 4. And this SDG 4 guarantees quality education. And quality education can only be achieved by reforming a curriculum so that it can meet the global standards. Then we have the benchmarking, what is happening across the world. Then we all know about the 21st century learning skills and approaches. This also informed the curriculum reform. Then we have the other sessional paper number 1 of 2019 on reforming education and training in Kenya, and it also recommended that curriculum, the competency-based curriculum was the ideal curriculum for our country. Again, also in 2016, before we launched the 2017 competency-based, we had a needs assessment, and this needs assessment was carried out in primary, in secondary, and even in tertiary institutions. And it also recommended that the curriculum should be reformed. And I have seen the previous presentation talking about the competency. And here we tried to bring out competency, a competency. What do you mean when you say that we need the competencies? And we are saying that competencies is where by the ability to apply knowledge, skills, values, and attitudes. And so that our children can be able to apply all this in real life situations. And we have flagged out about 7 competencies for the CBC, and the 7 competencies are communication and collaboration. We have self-efficacy as a competency. We have critical thinking and problem solving. We have creativity and imagination. We have citizenship. We have digital literacy. We have learning to learn. The previous speaker talked about learning to learn. And these are the 7 competencies that we want our children to have so that they can be globally competitive. Again also, I'm still explaining the competencies, the competency-based curriculum. Again, the previous slide, we are saying that we want values, we want value-based education. And again here, we came out with the values that we needed to our children to have, and about 8 values. Values of love, values of respect, values of responsibility, values of unity, peace, patriotism, social justice, and integrity, which we felt after we did all our research that was very, very important. Now, this is the organization of the basic education. This is how the basic education will be, that at the early years, what we are calling I, that is early years education, we have 2 years of pre-primary education. We have P1 and also PP2. This will be 2 years. Sorry, the previous one, I'm explaining the framework. Then after that, we'll have 3 years, what we are calling the lower primary. We have the 3 years, that is grade 1, 2, and 3. Then after that, we'll move to middle school. Middle school will take care of what we are calling junior secondary, and we'll take care of what we are calling the upper primary. And the upper primary is from grade 4, 5, and 6. And after that, the children now will transit to the junior secondary. That is 7, 8, and 9. And after 7, 8, and 9, sorry, I'm still on that framework. After 7, 8, and 9, then the children will go to the senior school. And this is where now, after the senior school, that is the 3 years in senior school, whereby the learners now will be absorbed in the training that you have for the health professionals. So it's very, very important that we understand that. Again, also, we are not also living, we are saying that CBC takes care of every child, and we are nurturing every learner's potential, irrespective of what kind of learner it is. And that's why we have based our curriculum on theoretical underpinnings of the multiple intelligence theory, among others. And we are saying that apart from what we are calling the age-based, this is now for the regular, those who do not have, any special needs. We have also what we are calling the stage-based. So all these children still can be able to be absorbed in the training of health professionals. We move to the next one. Now, apart from that, I thought that it was very, very important that we know that even when you are preparing the health professionals, or even even a teacher, there is the person we are calling the educators, the instructors for the universities and also for the health professionals and the trainers that you have and the teachers. We need also to upgrade the teacher who is training the teachers, the teacher who is training the teachers, that is the tutors. And we have also reformed the curriculum for the teacher education. And the reform of the teacher education, we have said that it should be a minimum, it should be a diploma, the minimum should be diploma. That is the teacher who will be able to teach. The P1, we have what we are calling DECTE, that is Diploma in Early Childhood Education. This is the teacher who will teach the children who are in P1 and PP2. Then we have the Diploma in Teacher Education, and these are the teachers who will be able to teach now, the primary up to grade 6. And after that, then we have also the junior secondary. We need also to take care of the teacher so that the teacher can be compliant, CBC compliant. We move to the next slide. We move to the next slide. So what are the implications? I asked myself, what are the implications of this on as far as the health professional curriculum and training is concerned? And I looked at the literature that was available, and I saw that they still need, or it has already happened in some countries, that the curriculum has been aligned to meet the CBC. You know, we have the competency-based training and education as far as health education is concerned in some countries. And the author says that, however, more research is needed. We need vigorous research, and especially when it comes to assessment and also to the evaluation of learning outcomes. Now we are no longer calling them objectives, we are calling them learning outcomes. And learning outcomes, we look at the product, the end product. Again also, that is also another author who is in the, talking about health professional training, and the author says that to be able to be CBC, to be able to be competency-based education, training in the health profession, we also need to define the educational outcomes for the health workers. Again, also we need what we are calling the individualized learning pathways. We also need to know what are the health needs of the community, of our community. What are the competencies, and which competencies do we need? And I've seen the previous speakers talking about the competencies. Then we also need flexible learning options. Which are the flexible learning options? Again, also, we need to know how do we assess the competencies? How do we assess the values? If we want a value-based doctor, nurse, or a teacher, for my case. Okay, so now my conclusion is that we need to align health professional training with the current competency-based curriculum, especially for the Kenyan context, so that when this learner leaves senior secondary and comes to the university or to Kenya Medical Training Center, then you know at what entry point are they. And also we need research, a lot of research, so that we can be able to reorganize health professional training at all levels. We need stakeholder engagement. In the basic education, we have done a lot of stakeholder engagement. We also need to benchmark internationally. We want also to know what is globally competitive, so that Kenya or any other country is not left behind. Then also, we also need to, as I have emphasized that the health professionals also need to pay attention to the senior secondary, because it is after the grade 12, which we are calling a senior secondary, that the child will enter into that profession. Again, also, maybe we need the organization of academic schools and departments. And again, also the orientation of the curricula from knowledge-based to CBC. We also need to know what is the duration of the programs, and what other new programs do we need to bring in. Like for our basic education, we have as learning area, we are calling health education. And this one came out of the needs out of the research that we did. So you need to know what other new areas need to come up. Again, also we need the orientation of the health education trainers, that is the instructors, that is the teachers, yeah? So we need these teachers who are training the health workers to be trained on pedagogy, the delivery. They also need professional competencies, and it was talked about, even that leadership. They also need to come out with what we are calling learner-centered pedagogy. They need to be reflective teachers and also mentorship of those that we are training. And that is the end of my presentation. Thank you very much.
And thank you so much, Dr. Wambaria, for a very, very interesting presentation delivered with a lot of energy on the competencies and the core values of CBC. Quite educative. I would kindly like us all to welcome our next presenter. You could walk over to the dais. Professor Hazel Miseda Mumbo. Yes. She'll be presenting on the relevance of curriculum development to quality teaching in health science training institutions in Kenya. Welcome, Professor. You could be talking a little about yourself as they prepare the PowerPoint.
Good afternoon, everyone. Good afternoon, or you are asleep. Good afternoon again. I'm Professor Hazel Miseda Mumbo. I'm the Vice Chancellor of the Great Lakes University of Kisumu. I am here to present on the relevance of curriculum review and development to quality teaching in health science training institutions in Kenya. Are my slides ready?
Not yet. You could tell us a little bit about Great Lakes.
Great Lakes University of Kisumu is situated at the shores of Lake Victoria. It's a very beautiful college that is science-oriented. We offer nursing, I think bachelor's in nursing and master's in nursing. We offer clinical medicine, and we are just starting a master's in clinical medicine. We are big in public health and community health and development. We also have physiotherapy, and I think we are generally health science oriented. We have education as well. Yeah, thank you. I think that's a good interview.
I'm so sorry, Prof. Thank you very much. They have currently misplaced your presentation. If you could allow Dr. Theory to start as we sort it out.
Okay.
Don't worry, we'll remember what you say. Dr. Theory, please. Our presenter will be Dr. Tim Theory. He's the current president of the Kenya Dental Association. He'll present on oral healthcare workers to adapt them for UHC, an integrated approach. And you know the drill. Before the PowerPoint comes, you can talk a little about yourself.
All right. It's coming up, right?
Not yet.
Not yet. So I can be talking.
Yes, please.
All right. Good afternoon, everyone. Let us stand up. Let us stand up. We look a bit dull from the lunch. Let us stand up. Yeah. We do our hands like this, and we turn around. Thank you. Thank you, thank you. We can now take our seats as we await the slides. Yeah, I think we are ready. My name is Dr. Tim Theory. I'm the current president of the Kenya Dental Association, one of the leading associations in the country who work in partnership with the Kenya Medical Association and the organizers of this event, that is the Ministry of Health and Kenya Medical Practitioners and Dentist Council. So the layout of my presentation is as you can see, and I'll ask us to move to the next slide as we try and, that's a list of abbreviations that we'll be seeing. I think to our guests, just take us back to the previous slide, to our guests and visiting delegates, of importance to us is the TVET, that's Technical Vocational Education Training, continuous professional development, which I'll be calling CPDs, of course UHC, NHIF, and KEDA. Next slide. So UHC has been recognized for enhancing healthcare and social cohesion, sustainable human and economic development, and is of course a precursor to strengthening national health systems. I ask, where do we put oral health in this? Where do we place it? And in the context of the conference that we are in today, where we are trying to harmonize training in the region and also match the students we are releasing to the market. Margaret Chan has described it as a single most powerful concept in public health that public health has to offer. And like the good professor said, that the aim of the philosophers have talked about life, but the aim of it is to change it. We have seen what the pandemic has recently exposed, and that is the weak links in our health systems. And as we have come to appreciate, the biggest thing that will hold any health system up is the healthcare worker. You could have good brick and mortar, you could have systems that have good health information management systems, but if you don't have a good healthcare worker, then this system does not work. And oral health is essential for general health, and what my talk today will be linking the two. That is the oral healthcare worker, UHC, and how we are training this person. Next slide. So what has been omitted as we are trying to bring oral health to our people? In Kenya, as we speak, we have about 1,426 registered dentists. This is from when KMPDC started registering doctors. This is in about 1972. Out of this, we have about 800 who have been retained for practice for this year. And out of these 800, about 400 are in public service, meaning that these numbers are still very, very small. And recently when NHIF, that is the body that has been identified as a carrier for UHC, was reconfiguring itself and in an attempt to bring UHC to Kenyans, when they were coming up with the UHC, what they call the UHC benefits package, this is what Kenyans will be getting the moment UHC is rolled out. Oral health was significantly left out. Yet globally, 1 in 4 people is suffering from an oral health condition, that is dental decay. The World Dental Congress, that is FDI, for those who are dentists, puts this number at about 3.5 billion people have suffered from tooth decay at some point in their life. So these numbers are huge. The economic impact of this is north of $2.8 billion annually. So these figures are significant. Oral healthcare workers have not been trained specifically. Go back. They've not been trained specifically to deliver UHC. So they don't know where they fall as they're trying to deliver UHC. So this has just been dropped to us and on our labs. And the feedback to the Ministry of Health is, as they are rolling out UHC, and today we are going, the president at Portrees is doing the second launch of UHC, is for us, or rather is for MoH, the Ministry of Health, to see how they train and sensitize the givers of this care as they are doing this to Kenya, so that they can understand what they are doing. In line with this, some of the statistics are that in 2016 to 2017, the reason, or the greatest reason for hospitalization of children between 5 to 9 years in England and other countries was Sweden and Romania, was dental decay. So these numbers are significant to us. And the effect of this neglect is that we are seeing a correlation that is in the risk space, where oral health diseases share modifiable risk factors with non-communicable diseases, and this has been something that is being talked about left, right, and center, NCDs. So oral conditions share modifiable risk factors. Also, the other effect of this neglect is the increase in the disease burden and the impact it has economically, and there's a disproportionate impact on the poorer and the less educated. Give me the next slide. and they happen to be the fourth most expensive condition to treat. And in low and middle income countries, the coverage and availability and access to oral health care, this includes early diagnosis and early diagnosis has been found to be lacking. And the impact of this has been that the correlation between oral health care and these NCDs, the likes of hypertension, diabetes, and their oral manifestations, has not been considered greatly. Next slide. So, what are the oral health cadres that are currently being trained in our country? We have dentists, we have community oral health officers, we have dental technologists, and dental assistants. For the last part, that is the dental assistants, there's currently an effort through TVET, and a skills sector advisory committee has been formed to try and make this course a competency-based education and training course. Next slide. So how do we move this apathy to action? I will bring to you a couple of arguments, and the first one is an epidemiological argument that this is the most common condition affecting human beings, and the numbers are as you can see here. And disability that is caused, or mobility that is caused by severe tooth loss is larger than in patients who are suffering moderate heart failure. The next argument in my next slide will be the economic argument. That is a cost of leaving these diseases neglected and the impact that they have when they are left as such. However, there are cost-effective treatments and strategies available, what we call the best buys as per WHO. The next slide. We have also a right argument to this, that we deserve the highest attainable level of healthcare, and oral health is one of these segments. And we need to be the advocates for our patients when it comes to this. Oral health is part of general health. We are treating a patient with a mouth, not a mouth in a patient. And we must interlink it with other pillars of sustainable development. And to achieve oral health goals, health systems need to be sensitive and responsive to other pillars of sustainable development. Next slide. We also need to form coalitions. That is, oral health professionals need to look beyond themselves and develop alliances with other professional groups so that we are able to deliver good care to our patients. And among the indicators for this is that you will see that if you have good oral health, and I will mention this a lot, is that you generally tend to enjoy a good level of life. So the how do we do this? Training should have aspects of primary health integrated in the curriculum. We don't do this a lot in training. We major a lot in curative services or modalities, root canals, extractions, surgical interventions, but few of our colleges where students learn from will ask them to go to the community so that they can see what is happening at the primary level of healthcare. There also needs to be what I will call a harmonized intercadre scope of practice. KMPDC is working on this, and I'm really looking forward to this beautiful document that will be released soon that shall be telling us what each cadre is supposed to do. We also suppose, the other how is that we should incorporate the basics of healthcare financing at postgraduate level so that we are able to ensure our doctors are equipped to know the impact of healthcare financing as they're delivering their services. Doctors, again, or the ones in training, should be taught about the basics of legislation. What role do they have in developing the annual work plans at their places of work? That is for those in public service. When the health committee says that there is public participation in a bill that they are moving, what part do we play? Half the time we are always reactive. We don't know what to do. We are waiting for the deans. And as we have seen from our previous speaker, they are heavily involved in other things. We are looking to the unions. They are perhaps engaged in other labor issues. but us at the primary level, what are we doing? The curricula should also emphasize on interventions responsible for the greatest burden of healthcare, such that you will see us majoring a lot on preventive healthcare. We should also standardize certain aspects of intercadre training, and this should lead towards interventions that are globally acceptable as effective, safe, and in the prevention and treatment stroke management of morbidity and mortality. This is at personal and professional level. So how do we prepare our future colleagues to change their behavior and attitude and techniques in view of this knowledge? One of the best places to start, of course, is continuous professional development, so that they're responsive rather to the current changes and trends in the market. I don't know how it works in other jurisdictions, but we should have to KMPDC now, Dr. Gadara, that a certain percentage of what contributes towards the renewal of your license, those points should come to from courses that are relevant to your discipline. Next slide. So as a Kenya Dental Association, what have we done to ensure that our colleagues focus on UHC? We have engaged in community health volunteer training, where last year saw us train north of 400 CHVs in Gatundu sub-county. We are doing a follow-up on this, just trying to see how we contribute towards this journey of UHC. As you can see there, we have some of our team members, Dr. Ganatra, Dr. Linus Degwa, Dr. Kituku Momo, who are engaged in this process. Next slide. The next one as well. So that is us conducting the training. So in summary, oral health is part of general health. Oral healthcare workers training should be standardized across the different cadres, and where jurisdictions differ on their requirements, then a standardized entry exam should be something that is considered. And the regulatory bodies and training institution and professional bodies should collaborate with each other when it comes to delivery of CPDs. Those were my references, and I'd like to end there, Dr. Gadara.
Thank you very much, Dr. Theory. And we have noted, as regulators, we have heard you, and thank you for the UHC aspect. Kindly note down any points of clarifications you would like as we welcome our last presenter for the day, Professor Miseda. Welcome.
Thank you very much. I hope my presentation is now available.
Yes, it is. Just a few seconds. It's loading. I think we're all looking forward to this presentation. It must be amazing.
I've said everything that I had to say. All the small talks are done. Yeah.
There we go.
Thank you very much. Being the last presenter, probably I will have a little more latitude.
No, not really.
Considering that I will not say. Anyway, I'm going to look at the relevance of curriculum review and development to quality teaching in health science training institutions in Kenya. And I want to say that the shortage of human resource for all cadres is a reality in sub-Saharan Africa, and there is no doubt about it. All the speakers before me and those that were there in the morning alluded to the same. And I'm happy that the discussion around curriculum has come at a time that there is need to actually review curriculums. This is a journey we started sometime in 2015, but I'm glad that the uptake is now, and I think God's timing is the best. So I'm going to look at some of the various studies that we've done in HRH in Kenya, especially in support of the various, in support of the Ministry of Health, and they all talk towards human resource and curriculum development. One of them is mapping of specialists, healthcare practitioners, and assessment of capacity of training specialist healthcare in Kenya. That was done in 2020, and it was for WHO. It was for Ministry of Health, supported by WHO. The other was cost-effective and equitable framework of training medical specialists in Kenya. That was done in 2019. Skills gap assessment. This was done in 2017, and it was in relation to leadership and governance at the time that the country was devolving. We were having a devolved system of government. We wanted to see how much, what was the gap in terms of leadership among CHMTs and all the health practitioners at the county level. I looked at assessment to identify the number and quality of pre-service graduates in Kenya. This we did together. I saw Professor Keyo here, but he's since left. We did that work with him. And lastly, performance needs assessment of health training systems which revealed that health workers' competencies and performance are wanting. So in essence, strengthening of health training institutions to increase the quality and quantity of the health workers produced is critical to mitigate global human resource for health crises and ensuring access to quality universal health coverage. And according to WHO, or according to literature review, because this has been said over again and over again, health professional schools are the main channels through which the health workers enter the labor market, and therefore they are key in addressing health workforce crisis. The truth is, much as this is the case, and we are trying to get quality and achieve universal health coverage, the professional institutions are underfunded and therefore operate inefficiently, consequently contributing to challenges of de-escalating the quality of health workforce production. According to the Institute of Medicine Committee on Conflict of Interest in Medical Research, Education, and Practice, if the learning environment provides the stage for education, the curriculum provides the script. And here we are talking about the formal curriculum, the courses required, and the objectives and the content of the curriculum. In the recent past, concerns have emerged calling the transformation of health professional education to better meet the conditions of evolving health needs of communities. This was referred to this morning, and this has been evident from the time we've had issues like HIV and AIDS, the non-communicable diseases and the rise cancer issues, and even now we talk of COVID-19, and we had the situation of Ebola some time back. At the time of, during the pre-colonial period, at the time that the countries, the African countries were getting independence, their main interest was to try and get quality health workforce that would be able to, that were commensurate to what they were, the colonialists were having. And at that time, they sent most of the doctors, both undergraduate and postgraduate, to study abroad, and so that they can bring the technology, or they can import the curriculum back home. What they did not realize was at the time that they were importing the curriculum that had not been reviewed over the years, the West was actually changing their way of teaching, their pedagogical methodologies. And a quick, they were replacing learning by rote and accumulation of integrated encyclopedia volumes of knowledge by promotion of self-directed and lifelong learning skills and personal development. A recent study, one of those that I mentioned, was looking at the cost-effective and equitable framework of training of medical specialists in Kenya. We had the opportunity to do a literature review and look at the trends in the world. We looked at South Africa, Egypt, we looked at Australia, Canada, USA, and the UK, Germany, and they were all having residency as a form of training of medical specialists. Meanwhile, in Africa, the sub-Saharan Africa, we still had the process of training, the medical, MED training, which is far from what is happening in the entire world. In fact, other than a few African sub-Saharan countries, there were literally none being trained the way we do in Africa. So what were the challenges that have come with this kind of training, the MED training? The challenges of postgraduate training in Kenya were as follows. Many curriculum for specialist training have not been reviewed and revised for a long time. And that, I'm talking of a study or a research that was done in 2019. That is very fresh. And training are not based on training needs assessment linked to disease patterns. The only training needs assessment that has been done in this country was done in 2015 and has never been repeated since. I'm not sure whether the counties are doing their own, but it is advised that they should have training needs to inform who to train. The other thing is that medical specialist training is heavily centered on national teaching and referral hospitals. And lastly, medical training takes doctors away from their workstations in the county. This brought a lot of problems. And some of the solutions that came from that study was that there's a need to review and change curricula to address changing situations and realities, and also be in tandem with technological advancement. The other was to need to explore medical schools using county teaching and referral hospitals as practicum sites for long duration. This would call for partnership and MOUs on use of infrastructure and clinical county staff. And I'm glad this morning the governor of Mombasa County alluded to the fact that they are actually able to treat and that they're having medical tourism in Mombasa. And the even more appealing thing was that the father was being treated at that very hospital. I also know that Kisumu, JOTRH is also performing well, and I think they have a collegiate system, and they're training surgeons and I think in family medicine in conjunction with Maseno University. So it's doable, and it is something that should be encouraged. And from literature review, there is almost no evidence as we speak today that most schools in sub-Saharan Africa have reviewed their curriculum since independence. It may have been done, but there is no evidence that alludes to that. So probably those who have done so may at least document or put it in a peer-reviewed journal so that it can give lessons to the rest. And the lack of review is stated as among the factors affecting the performance of professional nurses in Namibia. And institutions that have attempted review have failed to have their curricula address emerging national needs in the health sector, much less promote effective service delivery among their constituencies. But failure of the curriculum to keep pace with the evolving national health needs, including the chronic disease burdens in Africa, have greatly contributed to the deterioration of quality of graduates from these institutions. We conducted an assessment. It was a bottleneck assessment on what deters the training institutions from, health training institutions from performing. I zeroed in on the assessment of the curriculum, and I think there is a paper I've written, I've published in a peer review journal. This was sponsored by USAID, and it was a Funzo Kenya project. This was prompted by the Ministry of Health realization that after an assessment of performance needs assessment of the health training systems, revealing that health workers' competency performance did not conform to requisite standards stipulated by service and other regulatory bodies. Curriculum was not aligned to national priorities, with an average of 26% of respondents interviewed at the training institutions not sure whether the curriculum prepared students to adequately deliver the Kenya Essential Package for Health. The essence of this information is that curriculum development process should be more inclusive to ensure that countries' needs are taken into account and not just for monetary gains. In this assessment, we had a cross-sectional descriptive study. We collected data through structured respondent interviews among faculty, students in the health training institutions, key informant interviews, and desk reviews. The assessment purposively selected 14 institutions from the 18 institutions identified for initial collaboration with the project towards strengthening health workforce training. The statistical package of social sciences was used, applied to analyze data, quantitative data, and quotes used to illustrate perceptions. The findings were interesting. From the onset, we discovered that the training institution's leadership is actually male-dominated. Yeah, it's actually, I think let's go to the figure. It is actually male-dominated. Most of the people in the various institutions, be it institutional heads, faculty, and clinical space and faculty, were mainly male. Meanwhile, the females were students, slightly more, and then they were also in clinical placement. They were the managers, meaning that probably the matrons and the nurses are the ones who are at the forefront at this clinical site places. Then the general findings of this was really interesting. The assessment revealed significant qualitative and quantitative gaps in Kenya's training institutions, including in the curriculum, despite perceptions by some health training institutions that it responds to our national needs. In terms of ownership of institutions, 81% and 76% of faith-based organizations and private institutions, respectively, perceived curricula as responsive to the national health needs. However, respondents from public training institutions had the lowest perception in this regard, with about 1/3 perceiving the curriculum as not fully responsive to health national needs. But when you look at the curriculum that is being offered by the training institutions and what the government perceives as national needs, then there is a serious disconnect. One wonders if the training institutions really understand what the government perceives as their national needs. And for instance, the emerging diseases such as Ebola, now COVID, may be considered as the national needs from the action that the government has taken since they occurred. but they are yet to enter the curriculum of the training institutions. In their response, the stakeholders felt that the quality of curriculum was inadequate to prepare students for different settings. We shall see some tables towards the end to show that. On average, only 1/3 of the respondents felt the quality of curriculum prepared students to serve patients in emergency wards. The findings also reveal that curriculum do not adequately prepare students for clinical placement in a hospital setting. And similarly, students felt that the quality of classroom delivery of the curriculum was inadequate to prepare them for clinical placement. In the key informant interview, there were some interesting quotes or rather information, messages from the respondents. A faculty from a medical training institution said that the review of our curriculum is overdue. Many diseases have emerged that are challenging to university graduates because they lack teaching to handle them. It's not in their curriculum. Another faculty member said, short courses seem to respond to emerging issues than the pre-service training because these courses are not part of the curriculum. There is need to harmonize the two so that we have a well-trained professional to attend to emerging diseases. And one of the students said, the curriculum addresses national needs but does not adequately prepare us for practical required in service delivery. So when we looked at the structure of the curriculum governance structure, most of them indicated, especially the private institution at 92%, and the head of the public institution at 80%, said that they have these guidelines. But how they use them is what is in question. For instance, when you look at the next slide, you find that a question was asked whether the curriculum, whether they reviewed curriculums either annually, in less than a year, reviewed in 1 or 2 years, or in 3 or 5 years. But evidently, other than FBOs, most of the curriculums are not, especially those that were reviewed just less than a year is what is. But there's evidence that clearly curriculums are not a priority and are not reviewed as often. Others say that there is a need for a standard curriculum framework to guide the curriculum review for the health training courses. Because each training institution is coming up with their own things. Some say they have a community-based approach to training of medicine. Others have the integrated approach, while others have evidence-based. At the end of the day, they should all be released to the market in Kenya and should offer service delivery. How does this work? Was the question of one of the stakeholders. Another stakeholder said, the institutions do not include us in the curricular development, yet we are consumers and stakeholders in health. How can they claim their curriculum meet national needs? There has to be a consensus about this. So evidently a lot of, shall I say, interesting views from different quarters, but all they are all saying is that the curriculum does not meet standards and the curriculum needs to be harmonized and it needs to be reviewed to meet national needs and it needs to correspond to issues that are affecting the community and people today. Stakeholders involved in curriculum development, a third of respondents from public institutions stated that there was high stakeholder involvement for curricular development. but only a third, only 13% of FBO respondents and 18% of private institutions perceived high stakeholder involvement in their curriculum. Probably this is because that the private institutions are commercial, and the FBOs have international curriculums from other countries. So looking at stakeholder involvement in reality, we realize that the perception, the stakeholders, hardly 50% of the respondents indicated that there was involvement. So there is really need for stakeholders or maybe holders of the stake to participate and bring out emerging issues. And I believe this conference is actually addressing that need. Satisfaction of quality of curriculum depending on classrooms, skills lab, clinical practice, provincial hospital, district hospitals, outpatient clinics, health centers, maternity ward, emergency ward, community service, all indicated, all the percentages less than 75 was inadequate. But we realized that all the respondents in the institutions, faculty, students, clinical placement indicated that the quality was not adequate. Then there are issues, we asked for best practices, the best practices on training of the health workforce. And they said the first one was timely review of curriculum to include current issues in health was one of them. Aligning theory and practice by increasing more practical learning. I think I've not finished with that, yeah. Enhancing participation of all stakeholders, including students. Community needs addressed in the curriculum. Available learning resources, both human and infrastructure. Level of lectures, training and students entry level. Technology to be integrated in the curriculum. So they were in order of importance. And so the recommendation of that study was that the government and health training institutions should prioritize curricular development and review in line with health sector needs. There is need to establish joint committee for curricular review to incorporate clinical instructors and preceptors at clinical placement facilities with dissemination plans for relevant policies and guidelines for all. And curriculum development and review and governance should be strengthened to ensure quality of content and delivery. The two takeaways from all the studies that we've conducted or that I've done, a hybrid of university and collegiate system to be used to train medical specialists. For this will increase numbers and will improve quality. Leadership and governance should be part of the curriculum for the health workforce. Thank you very much.
Thank you very much, Prof, for a very well-researched presentation. Now we are welcoming questions. I think we'll take all the questions, then you note, and then we can respond. Yes, sir, please come here.
Good afternoon.
Good afternoon.
My name is Donald Kokonya. I'm the Dean, School of Medicine, Masinda Mdiro. And I've been an appointed dean, elected dean, and I've developed MBCHB curriculum. These presentations are very good and crucial. I wish we had sessions that can deal with these three presentations. But I have very brief comments. To start with, MBCHB curriculum in whichever country is the property of the World Medical Association, and it is 66% competence-based. So the introduction in Kenya of competence-based education applies to standards below MBCHB, but not MBCHB. It's a pure practical skills development program. When we come to the relevance of our program curriculum, no curriculum in Kenya in the health sector is done without stakeholders. Stakeholders are there. The program must be aligned to government policy, and participation is wide. So we usually do this, and every senate in any university requires that stakeholders have been involved, and before that, a feasibility study has been done to justify mounting of that curriculum in any university. So this is there with us. Now, the strength of a curriculum is not a matter of subjective opinion. It's driven by the ability of the curriculum to produce products which reduce mortality. Between 1995 and 2015, we may be surprised to find that Eastern European countries, which invested strongly in basic education of the MBCHB curriculum, produced much lower mortality than Western Europe and the US, that is UK, US countries. And now MBCHB curriculum is moving towards stronger basic education. And we are employing pure scientists, biochemists and all that, to ground these students. Now they use this knowledge all the way to their retirement period. So I would have liked this presentation to have another forum so that we can look at the issues. Now, for the last presentation, a student is unlikely to have a participation in the time of curriculum, but curricula undergo mid-term review. And that's the time when the experiences of the lecturers, experiences of the students are captured. So what we can say is, are there academic institutions that don't do mid-term review? Otherwise, you cannot change a curriculum, particularly health curricula, unless they have gone through their full cycle. So probably would have had a bigger session. Thank you.
Okay, thank you, Dean. Well noted. There is the email for the Secretariat. Kindly add anything we might not have been able to address. Is there anybody else? Oh, yes. Please come.
Thank you very much, and probably just to congratulate the speakers for...
I'm so sorry, please.
For making us, for giving us useful points to ponder as we go through curriculum review. And I strongly support what my colleague says. As a former dean, I know that there's always wide stakeholder engagement. My only question to the presenters is basically that there are certain frameworks that are provided by the governing institutions, Commission for University Education, Kenya Medical Practitioners and Dentists Council, in the form of core curriculum. What role do these guidelines play in straining any adaptation of curricula to changing societal needs? Maybe Professor can try to answer that, and we know exactly what is it that brings about the lack of coherence between the curricula and, of course, the needs that we seek to serve, to adapt that healthcare worker. Yes, we borrowed heavily from the West, but are the governing organizations more conservative than the academic institutions? and thereafter, so when there's a curriculum review, we seek to conform to a certain write-up and not let organizations have some freedom to input other content. Thank you.
Thank you, Doc. Professor, you have agitated the deans a little bit. Yes, yes.
Thank you very much. My name is Alice Lakati.
You will have to tiptoe, or we can disconnect the microphone because we can't hear you.
Thank you for this opportunity. My name is Alice Lakati. I'm the Director of Research and Dean at Amref University. My comment, I think, and question is to the presenter from dentistry, because we all know that this is one service that is very expensive to train and is really important for achievement of UHC. Listening to you, I feel that there is an opportunity that can be taken by this field towards achievement of UHC. One of them is, I don't know about your involvement in CBC, because that is where we start to make changes in terms of oral health from a very early age. And I know that, and I think my dean, Dr. Odhiambo here will confirm that most oral health diseases are actually at that early age. We need to optimize that opportunity towards UHC for dentistry, because it's not going to be given to us. The other thing, I think there is also a cadre that probably, I don't know how they are involved, oral health officers. I'm happy to see that there is work towards TVET, because in every county, you can't actually get a dentist, and it is quite expensive. And this is a field that UHC, there is an opportunity to optimize. Thank you.
Thank you very much, Doc. Before I choose the next person, anyone with a question on CBC? So yeah, CBC?
Thank you. My name is Joseph Abuya from MoH University School of Medicine. I had a question to Professor Mumbo. She said that faith-based organizations get their curriculum from other countries. And I'm sure Uzima is a faith-based organization. So does it mean you got your curriculum from another country? And if so, why didn't you develop yours? Secondly, to the same presenter, you alluded that we should continue the training of MMed both in university and as collegiate, maybe like COSEXA. So I thought that probably let us see the products of those who come from the formal traditional MMed training and those from collegiate training like COSEXA, do a study and then be able to conclude with all the evidence that it's good to continue parallel with the two kind of programs. So I don't know how you came up with this suggestion that training should be both parallel so that you can increase the numbers of specialists whom we have. I don't know how you came up with this. Then, Dr. Theuri, you have talked about the oral health officers and their regulatory bodies. Currently, I believe that the oral health officers are regulated by the Kenya Medical Practitioners and Dentists Council. So when you talk the way you talk, does it mean you are about to give the oral health officers have their own regulatory body? Why are they still being regulated by the KMPDC? Thank you.
Thank you very much. Okay, I think we'll take the last two questions. I was really hoping to get something from CBC. Professor Ganda, do you have anything to say on Uzima? You are maintaining peace with your curriculum?
Thank you very much. My name is Ganda.
I just want to respond on an allegation that has been made here, that our curricula in the private universities come from abroad. That's not true. The Ozima curriculum actually was, when Ozima was starting, was more or less copy-pasted from that of University of Nairobi. And we have gone the 5-year, 6-year cycle. We have just finished reviewing the new curriculum. And most of the things we are talking about here, we didn't know that we're doing the right thing when we are doing the right thing. Like we have now introduced, because the first, in the 4th year, we have the clinical, introduction to clinical medicine. In fact, we teach them everything. For example, in internal medicine, and we realized in all universities, because I've taught both in University of Nairobi and University of MoH and now Ozima, I realized what we teach in 4th year is basically what is repeated in 6th year, and we thought that we were more or less wasting time. So what we have now decided is that because by the end of the 4th year, there are basically, if he's a pediatrician, if he rotates in pediatrics or internal medicine, basically this guy already has some idea. That is how we were trained for 1 year, then you go out. Now we have decided that we'll be sending them out at the end of during the 5th year to the periphery, to the peripheral hospitals, the county hospital, so that they go and get attachment there for 6 weeks, and then also in the final year. And that they will learn more. Then we'll be concentrating more on the management aspect of medicine rather than going through again the same thing that you taught in 4th year. Now you want to start teaching it again. There is this misconception that 4th years are given just introduction. Then 6th year, now you concentrate on management. It doesn't work. I can tell you that because I've seen you repeat the same thing over and over again. It is very boring. Thank you.
Thank you, Prof. I thought we'd have a slight commercial break. I had a question from here. Then I think we'll take the last one, and then we can hear the answers. Welcome.
Hamjambo.
Hatujambo.
Hamjambo wote. One of the things that I was looking for and I did not see, we've mentioned several very important things, including problem-based learning, experiential learning, but we've gone through all the sessions, and I can assure you that the audience was sleeping quite a number of times because they were not engaged. And I think when we are developing this curriculum, we are talking about how to engage the learner or how to engage the listener, or using those techniques that will make the learner or the listener search for the knowledge. The other thing that I've observed is there is over-concentration on medical issues and not health at all. I, as an example, Professor Ogendo, as an example, went through the first year on basics, anatomy, biochemistry, physiology, etc., and slowly got introduced into the illnesses. And none of the universities actually have a solid foundation on how to maintain health and wellness. And really that is where we should go if we are trying to get a healthy society, and also to reduce the cost, the very heavy cost of treatment, which calls for the future. Actually, this thing was about the future. The future anchorage of health education or medical education should really be at the household level. We use the household as the platform for people to learn about people. That all the students should start by living in different households and being assigned how to find certain basic facts within households. Because if you go into hospitals right now, for example, at JOTRH, you get a lot of people with things like anemia, and this anemia has far-reaching implications. It means they don't eat properly. It means there's something wrong with their production of red blood cells. And you come and work out that anemia and try to treat it. Live and work in the community and be assigned what to measure. And also, apart from assigning them what to measure, they should take advantage of technology where they are at the community level as one way of supporting learning and teaching. And this doesn't come out very, very well. We're talking about high-level medical coronary was raising here today. Coronary, you've missed out on simple things for all your life. When we are talking about dental caries, people have not adhered to the right dietary what they're eating is wrong, and we wait at the other end for them to come with dental caries, which is the highest illness in any part of the world. So that in addressing the future of curriculums, can we kindly go backwards and see whether we can now divide 75% of training anchored at the household level, where people live, at least grandmothers were teaching people where people. Thank you.
Thank you very much. Then the last one, and then you can wind up.
Thank you very much. My name is Jam. Team, thank you for your presentation, and you have really, the country is embracing competency-based education and training. That is an aspect or a facet of the colleges, or what you used to call tertiary. I would like to, because I've seen you highlighted dental assistants, dental technologists, oral health officers. These are in the facets of the level 6 and level 5. That is a diploma and certificate. Exactly as a country and other parts of the world, these are the major contributors of the economy. When you go to the county levels, you expect to see so many community oral health officers. You expect to see technologists and that kind of cadre. As the president or the KDA president and also a member of the representative of the KMPDC, right? Do you have any plans to embrace CBET so that you open up the training? Right now, the training is only in 3 colleges in the country. Ladies and gentlemen, Mount Kenya University, only in Nairobi and Nakuru campuses, and which was the other one? Mount Kenya University, yes, KMTC, University of Nairobi for the degrees, okay, and MoH. So we need to open up this kind of training so that our Kenyans can receive services. This can only happen when we introduce the CBET in TVET colleges. TVET not only takes care of the technical vocational education training in the public. We have private institutions that are now training medical and health personnel in the diploma, at the diploma and the and certificate levels where applicable. We need to open up. Mr. President, do you have any avenues to open up? Because we cannot keep on saying we need these officers, but we do not have a curriculum, a national curriculum that is open for everyone, especially the TVET sector. Thank you.
Thank you very much. I think, Mr. President, you will start us off. And then, Prof, I think Dr. Wambaria, your presentation was perfect.
Does it work?
Oh, it's not working.
Yeah.
I think I'll just stand and take the questions in the order in which they came. The first one was a suggestion for involving oral health in CBC. We had written a note, but I'll follow it up. That's a good observation, and I will pick it up, and hopefully we will see the efforts of that in the books our children will read. KDA in 2017-2018, we undertook to see about 20,000 children. This is between the age of 5 to 8 in 6 counties: Nakuru, Nairobi, Murang'a, Meru, Machakos, and Kajiado. And what we saw is, by the time you are attempting to see these children, even a 5-year-old, if dental decay ought to have, if this child has had dental decay or will have a chance of decay happening, it will already have happened by the time you are reaching them there. And one of the best buys that we thought of was integrating oral health education in the MCH clinics. That is when mothers come for their prenatal clinics, let us have some form of oral health awareness at that particular point. And what we usually say is, who are the people who should see a dentist? The criteria is just 2. If you're alive and you have a mouth, you should see a dentist. That is what we were saying. To Dr. Abuya, a once-time teacher, KMPDC is in charge of regulating community oral health officers and dentists as well. I am not deviating from that position. In any case, regulation should be centralized with one body for all cadres, and we do hope that technologies and when dental assistants have a curriculum and subsequently become professionals, then they should also be regulated by the same body, so that we can have harmonization of the same, so that when a scope of practice is released, it is released from a point of from one body, so that it makes sense. The other one was on community oral health officers, and perhaps how I understood the question was their level of practice. They're generally trained to practice preventive and promotive dental care. And this is at primary level healthcare facilities, level 2 and perhaps below. And the referral system should be streamlined so that when CHVs are able to pick a particular oral health issue from the charts that they do have, once that has been escalated, there's a very clear referral mechanism up towards level 4 and level 5 facilities within the county, so that we can have some form of filtering that is happening. That would be my take on it. And perhaps to add to what I've seen happen, I think MoH University has some form of community-based education system where the students, I think in year 1, 2, and I think 3, are sent to the field to see what is happening there. And I know also the field looks like. You in the clinic, there are other facets to it. So I think there's already efforts that are ongoing around that, and the effectiveness of that is very good, because I know they do make proposals and generate some research data out of this. To CBET, I think that was Jamlik who asked a question on that. Health courses have some form of quality control to them, whereas we may want to provide them to everyone or increase access. I think there are minimum requirements that have been set out by regulatory bodies on what these students should first of all have had before they can qualify for these courses. And if this is not clear, then there's usually an entry exam into the profession. So to empower practitioners with, I think it's very in the curriculum. And as I think the Associate Dean from Masinde Murillo said, that it's basically a competency-based, 60% of it is a competency-based curriculum. So what parts of this do you want to augment with TVET? That would be my question. And what is the need that you're trying to plug in the industry? And is it relevant to what such an attempt will be trying to do? If the answer is yes, then it makes sense. If you're releasing safe practitioners, then the answer is yes. And if there's a way we are going to regulate them, then the answer is yes. If there's a no to any of that, then we'd have to stop and just take the slow growing path of creating a good quality oral health.
Thank you very much, Dr. Theory. As Professor walks to the podium, I've been requested to announce that the buses leaving for Jesus will start leaving from 5. So maybe Prof, you'll just answer briefly.
Thank you very much. I'm happy that my presentation has solicited a lot of reaction, and which means it's a problem at the heart of the health sector. When I say that curricula was not reviewed by various training health institutions, I did not refer to universities per se. We looked at all the training institutions, including the faith-based institutions such as the NUEC, Kijabe, and the likes. And of course, the training, the residency training in those institutions are actually by various organizations or institutions or people from mainly the US. And therefore, their curriculum has not been, probably if not reviewed, then it's because they get them from the West. And Uzima is a university like any other, and if he says that they copy-pasted the curriculum of Nairobi, then it looks like that trend leaves a lot to be desired, because ideally curriculum should be responding to needs. But as I said, and somebody asked, the national needs and the training institutions have a serious disconnect, because the national government reacts to situations. When COVID comes, they react to it. There is no planning. When HIV and AIDS came, they reacted. When Ebola comes, they react. So at that time, that becomes their national need. But the reality on the ground is that even the entry level, especially for nurses and clinical officers, you find that the training institutions admit students with less qualifications than what the government expects. So once the students have gone through the training in the health institution, then the regulatory bodies or even the government refuses to employ them. I happen to have been the public sector advisor at the Ministry of Health for a period of 7 years. I was seconded by USAID and thereafter JICA. And I saw the pain that people are going through because they do not understand. The government and then the training institutions have never sat to agree on what is actually our need or planning as a sector. Then during the time that devolution, when the country got, the devolution system of government came into being, there was an outcry by the counties because the government was taking students for training, for specialization training, and yet there were no there were no professionals on the ground to actually deliver services to the constituency. And therefore, you found that some counties like Kirinyaga literally refused to allow their doctors to go for training. And that prompted the Ministry of Health to understand what is the cost-effective way of training the health workforce in a way that they do not, to increase the numbers, and also they do not neglect service delivery. At that point, USAID, MoH requested USAID to support that assignment, and that is where the collaget issue came. And we realized that if we have to increase numbers of a health workforce that can be able to take care of the much needed service delivery, then we have to actually have the collaget system as well as the medical, the MED, because the reality is that the MED is, you cannot take so much. It depends on the capacity of the institution, and probably they can take maybe 10, depending on the faculty, depending on so many things. But if you complement it with residency, the people will not move from their place of work, and yet they will still gain the much needed expertise to support the sector. I believe that those were the main sticking issues, and I thank you very much.
Thank you very much. I request we applaud our presenters as they leave the podium, as I hand over back to the overall chair.
Thank you very much, ladies and gentlemen. I think that brings today's session to an end. Mine is just to thank you all for your participation, which was very active, and it is much appreciated. I think now we can prepare ourselves for the evening event. As you've been told, transport leaves at around 5. If I can just ask the rapporteurs for this session just to remain behind for a few seconds of discussion. As for the rest, let us meet tomorrow morning. I believe we start our first plenary at 8. Thank you very much. So if the team recording can just remain behind for a second.
Hello.